So radiation therapy is primarily a local treatment modality. So we treat localized tumors, for example, of the head and neck, prostate, brain tumors, and frequently we're unsuccessful. And so, of course, we want to make this better. And the paradigm to date has been to use chemotherapy with radiotherapy to make local control better. But this has only been marginally successful and achieved at a very high toxicity expense. Also, what defeats us, in addition to local treatment, is the fact that tumors metastasize, that they spread away from the primary site. And so what we're hoping to do is to combine radiotherapy and immunotherapy not only to improve local control, but to affect the treatment of systemic disease, that is, to affect the treatment of metastasis. So what we found is that when radiation is given in high doses, it liberates danger signals that alerts the immune system. It stimulates cytokines such as interferon and tumor necrosis factor alpha, which also not only alert the immune system, but seem to improve the antigen-presenting cells, which present antigens to T cells and activate T cells, and in general promote T cell priming, which is the general activation of T cells to go and then kill tumor cells. What we found is that by the use of the so-called checkpoint inhibitors, these anti-CTLA-4, which suppresses the priming phase of T cells, or anti-PD-1, which suppresses the effector phase of T cells, by combining these molecules with radiation, we can not only improve the local control of tumors, but we can set up a systemic immune response that under some circumstances can eliminate tumors outside the primary site. Well, it looks as if we change the local tumor microenvironment so that we get infiltration of T cells, and there is some cross-reactivity between T cells and the local tumor microenvironment, at least under some time, and tumors outside of the irradiated field. This is known as the abscopal effect, or an effect away from the primary tumor. What we found is that what goes on in the primary, or the irradiated tumor, not only stimulates T cells, but it eliminates or decreases cells called myeloid-derived suppressor cells. These are complex cells, and their natural function is to promote wound healing and suppress the immune response. In tumors, these cells seem to dampen down T cells, and it seems as by combining anti-PD-L1, which is the ligand for PD-1 in radiation, we can not only take the brakes off the T cells to kill the tumor cells, but encourage the T cells to secrete a cytokine, tumor necrosis factor alpha, which kills the myeloid-derived suppressor cells in the tumor microenvironment locally, and it seems as if also outside of the local irradiated tumor, although this is under investigation now. These are preclinical, although others have done studies. There's a paper in the New England Journal of Medicine using ipilimumab or anti-CTLA-4 in radiation, where the colleagues of Jed Walczak and Mike Postow from Memorial Sloan Kettering show irradiation of a local tumor, or of a tumor in the chest, cause regression of tumors outside of the irradiated site in a patient who was not responding to ipilimumab. This is quite interesting because the patient went into remission 4 years, was controlled everywhere but the irradiated field. So my colleagues in immunology just think, well, we can give any old radiation to wake up the immune system. But my suspicion is that we need to give curative doses of radiation within the field, that it's more that we should not throw out the cytoreductive properties of radiation in favor of the immunogenic properties of radiation. So far, because it's been fairly limited in confined volumes, there hasn't been much toxicity. In my presentation, I'll talk about anti-PD-1 antibodies in lung cancer, which have been a remarkable change. My suspicion is that this will be brought up front with radiation therapy for unresectable lung cancer. And under these circumstances, I think we might see pulmonary toxicity, since the acute effects of radiation and the acute effects of PD-1, anti-PD-1, are both inflammatory, and this can cause problems, and we'll have to find a way around this. In the long run, I actually think radiotherapy and immunotherapy will supplant surgery and chemotherapy, or not completely supplant it. But I think when we find out how to integrate radiotherapy and immunotherapy, we'll be able to suppress microscopic disease outside the field and cure large primary tumors within the field. I think in this metastatic setting, I think it's going to be more complicated in the context of how many tumors can we irradiate. My colleague Samuel Hellman and I have put forward a hypothesis called oligometastasis. That is, some patients only have a few metastases that can be cured with radiation alone. And it may be with newer methods of image guidance for radiation, we can treat quite a lot of metastatic tumors. And this, I think, will go a long way toward curing metastatic disease. This is likely to be more complicated and involve targeted agents and chemotherapy and so forth.